introduce first today's guest speaker. He is a professor of economics, Dr. Rammohan, and Director of International at the UWA Business School. He is the Senior Fellow of the Australia-Indonesia Center at UWA. Her research expertise is in development economics, health economics, and agricultural economics. Focus of our research has been on understanding household level socioeconomic factors that can influence maternal and child health outcomes, gender, and food security issues in South and Southeast Asia. Her research has been published internationally and she has received research funding of over $9 million through competitive research grants from Australian Research Council, DFAT, Australian Council of International Agricultural Research, and Australia-India Institute. Professor Anu currently serves as a member of the Australian Research Council's College of Experts and is on the editorial board of Economic Records. Last but not the least, he is amongst the mentors of myself that when I was studying PhD there, and I had a few meetings with her regarding my PhD thesis, which was also on food security policy analysis. So thank you, madam, for your time and devotion for the subject. Let me explain that to our call, more than 150 registrations were there through Google Forms, and I hope that we'll be having around 100 plus attendance today. The registrations were around Africa, Turkey, Nigeria, Benin, Pakistan, India, United States, and Australia. And I hope that we'll be having a very good discussion today. Without wasting any time, over to you, madam, please.
Thank you very much for inviting me. I'm really happy to be here. Can I please share my slides?
Yeah, sure.
I can, yeah. Yeah. Can you see my slides now?
Yes, yes.
Okay, thank you very much for the opportunity. I'm really happy to be here. So let me just start off by saying that achieving sustainable global food and nutrition security is a big challenge. So we see that globally, about 12% of the world's population had suffered from severe food insecurity in 2020, which means that they have gone without food, like they've experienced hunger and gone for days without eating, which is approximately 928 million people worldwide. Also, there are challenges towards meeting the Sustainable Development Goals, which has a target 2.1 to end hunger and target 2.2 to end all forms of malnutrition, which means stunting, wasting, overweight, and obesity by 2030. At the same time, achieving environmental sustainability goals. So what I want to do in this presentation is talk about three aspects. One is increased food production. We have seen that agriculture has transformed. We have many new crop varieties and livestock breeds. And along with this, we have seen a combined increase in inorganic fertilizer usage, manufactured pesticides, machinery, and larger field sizes. So I'm not going to focus on the food production aspect, but what I want to say is even though food production has increased, and to some degree we see food security has improved, what we still see is that we still observe nutrition insecurity. So what do we mean by nutrition insecurity? We mean that because of the high cost of a healthy diet, we see that a lot of hidden hunger, where people's calorie intake is sufficient, but the quality of food does not meet the nutrition requirements for a healthy diet. In particular, we observe that maternal and child nutrition is unacceptably high. So what I want to be doing in today's presentation is focus mainly on maternal and child nutrition, but mostly focus on Southeast Asia and mostly look at what Pakistan has been doing, because it's also good for me. I've learned a lot due to this presentation. So if we look at the challenges to maternal and child nutrition worldwide, we see that globally more than 149 million children and 45.4 million children under 5 years of age were stunted, which means their height for age was below the reference population for their age group. And wasted, which means their weight for height was also quite bad. And we see that South Asian region, which is India, Pakistan, Bangladesh, Nepal and Sri Lanka and Afghanistan, they account for over 40% of stunted children worldwide. And if we look at the 3 countries that account for the stunted children across the world, we see that India, Nigeria and Pakistan are the 3 countries with the largest number of stunted children in the world. And we see that India also accounts for the largest number of wasted children in the world. So imagine 46.6 million children under 5 in India are stunted, and in Pakistan the figure is 10.7 million. So what we see that, of course, these are large countries with big populations. So what we want to understand is what are some of the reasons why we observe this high level of poor child nutrition. So wasting is often caused by food shortage or disease. For example, if the child has diarrhea or is frequently sick, then their weight is affected. And we see that this is a strong predictor of child mortality, which is children under 5 years of age dying. So what are some of the potential causes for poor child nutrition? Child nutrition is poor child nutrition or malnutrition among children is a leading cause of child mortality. So what are some of the reasons for why we observe child nutrition levels to be low in many developing countries? One is low birth weight, lack of appropriate infant and young child feeding practices, which means that young children are not breastfed, or they don't have good quality food, poor hygiene and sanitation conditions, which means that repeated illnesses, diarrhea, and infectious diseases are some of those reasons. At the household level, of course, poverty, low food security, and lack of dietary diversity. Like what we observe in many parts of South Asia, like in India and Pakistan, for example, we see a lot of diet is dominated by rice or wheat, and there's less, children don't get much access to meat, vegetables, and fruits. I'm talking about very, very poor children here. And then we see that the children have very poor access to health infrastructure. And then we see that there's a tendency for early marriage and childbearing, which increases the risks to maternal health and child nutrition. For example, India has among the highest number of girls who are married before the age of 18 across the world. So India, Nigeria, and Bangladesh are 3 countries where childbearing is very high among under 18-year-olds. So what this does is that if a person is still growing themselves, like adolescent girls, if they're having children when they're 15, they're 16, then what happens is that it affects the chances of the child surviving. It affects the maternal nutrition as well, because they're also at a growth stage. And oftentimes these are young girls. They don't have the knowledge or the education to know how to address some of the small health problems that their children may encounter. For example, if the child is having diarrhea, a simple thing like ORS, like oral rehydration therapy, giving the child fluids, will ensure that the child will, survive. But if the mother doesn't have that knowledge, then that becomes a problem. And then maternal undernutrition during pregnancy, what results in what we call the triple burden of stunting, wasting, and underweight among children. So the links between maternal and child nutrition have been well identified in much of the previous literature. So the literature has identified three main conceptual pathways through which a woman's status in the household can influence child nutrition and household level food security. The first one is that the mothers will influence the nutrition status of their children through their own health when they're giving birth, when the child is young, and when the child is a teenager. And we also see that the provision of appropriate breastfeeding and complementary feeding practices will also mean that the mothers can influence child nutrition. And thirdly, their influence over the intra-household allocation of resources. We know that in many South Asian communities, there is a strong preference for sons. There might be less resources available for the girl child in terms of food and access to medicines. We also see that, does the mother have knowledge about cooking nutritious food and so on? So it's very important that we have, mothers have that knowledge to be able to provide a nutritious diet for their children. And then we see that the significant association between maternal and child nutrition status runs in both directions. For example, maternal malnutrition severely increases the risk of a low child birth weight and subsequently infant morbidity and mortality. We also see that the additional nutritional stresses of pregnancy will exacerbate or worsen the problems of the mother's own nutrition status and her own morbidity, which is her illnesses and her own mortality in later life. And we see that appropriate infant feeding practices in the first 2 or 3 years of life are essential for the survival and development of infants and children. We also see that better educated women have greater decision-making abilities. They will participate more in their communities and they are better able to adapt appropriate feeding practices and care for their children. So what about maternal nutrition? We often find that while we have a problem with child nutrition, there is also a problem with maternal nutrition. We find that there's a triple burden of malnutrition for pregnant women. We see that there is undernutrition due to energy and protein deficiency. This means that either they are very thin with very low body mass index, or they have very short stature. And next we see the problem at the same time of obesity. And this could be due to consumption of calorie-dense types of food and very sedentary lifestyle. And then we find that there is micronutrient malnutrition, where there's deficiency in vitamins and minerals. And in South Asia, we see the big problem in India and Pakistan of anemia, where nearly 50% of pregnant women or 40% of women in the childbearing age group are anemic, which means that they have insufficient intake of micronutrient-dense foods and poor bioavailability of micronutrients such as vitamins and iron and so on. and which they need more of during their pregnancy. And what this does is that anemia decreases the iron stores that are available for the baby, which means babies that are born to anemic mothers will also have problems with growth. So this I've taken from an article on Pakistan by Mirza and Ahmed, and they've looked at the National Nutrition Survey of Pakistan between 2001, 2011, and 2018. And for changes in child nutrition status, they have looked at different indicators like stunting, wasting, underweight, anemia, vitamin A deficiency, zinc deficiency, iodine deficiency. And what they're able to show is that stunting has declined fair little between 2001 and 2018. And this is not just a trend in Pakistan, but also in India. Even among rich children, stunting among children under 5 is very high, like 40%. Wasting is not that bad, but it has increased slightly. Underweight has gone down in Pakistan between 2001 and 2018. Anemia has also gone down among children, but even then we see that more than 50% of children that are born are anemic. And then we see vitamin A deficiency has gone up a lot. It's now 51.5% of children. Zinc deficiency has declined a lot. Iodine deficiency has declined. So we see anemia is still very high, stunting is very high. So these are two policy areas that the government is trying to address. So stunting, anemia, and vitamin A deficiency are big problems for children in Pakistan. If we look at changes in women's nutritional status using the same period of time, we see that the proportion of women that are underweight has gone down. Anemia has, for some reason, went up in 2011, but has declined again, but it's still over 40%. This is anemia among non-pregnant women is about 39.3, which is a bit of a concern because these women might become pregnant in future. And these are pregnant women, anemia among them is about 48%. And then ferritin deficiency has gone down a lot, and that might be because many provinces have adopted zinc fortification type of programs to address nutrition problems. We see vitamin A deficiency has gone down as well among mothers, and we see that's gone down for children as well. Zinc deficiency has gone down, and iodine deficiency has gone down by a lot. So what we are observing, the broad trends, is that anemia is quite high among mothers, and we also see some degree of vitamin A deficiency. And among children, we see stunting, anemia, and vitamin A deficiency. So I found this article where they have looked at all the programs that have been implemented in Pakistan to address anemia among children between 1950 to now. So over a long period of time, we see between 1950, in 1990, for example, we see anemia rates were quite high. So if we look at prevalence of anemia, that was about 70%, and that has gone down quite substantially. But what we see here is all the different programs that have been launched to address this over the period of time. So we see that many efforts have been made to address this, and there has been a lot of efforts, lots of programs, and some indicators have improved and some have not improved so much. So we don't know exactly which ones have improved and which ones haven't. But if we look at the previous figure, we saw that there has been iron deficiency has certainly gone down, and zinc deficiency has gone down. Underweight has gone down, but anemia still remains very high. So if we look at the latest data, what we see from the National Nutrition Survey from Pakistan, 2018, is that we still see high levels of macro and micronutrient deficiencies among women of reproductive age. About 14.4% were underweight, 24% were overweight, and 13.8% were obese. We see a high prevalence of anemia, and vitamin A deficiency was about 22.4%. In addition to that, we see that 37% of households faced food insecurity, which meant that about 177,000 annual deaths in Pakistan are linked to maternal and child malnutrition. And then they set up the Pakistan multi-sectoral nutrition strategy program. What they try to do here is to identify what are the channels through which the malnutrition affects child growth. So you can see that this diagram provides a really good picture of what the problems are. So what they say is that one problem is, if you start with the first one, insufficient dietary intake, which means that even though food access is poor, which means that energy intake is 58% of the recommended levels, and 68% of households cannot afford a basic nutritious diet. And then what the other issues, and that could be because of lack of resources, due to social, political, and economic context. It could be due to poverty, or it could be due to knowledge and access. What that's doing is it means that childcare, it's impacting on childcare, and it's impacting on water and access to feeding practices, for example. So suboptimal childhood care and feeding means that less than 4% of children who are aged 6 to 23 months enjoy the minimum levels of dietary diversity, and less than a third are protected by exclusive breastfeeding until 6 months of age. And then they talk about the home environment and basic sanitation situation, where 50% of people have no access to piped water or improved sanitation. And then in terms of health services, only 33% of pregnant women fully attend the 4 antenatal care services that are recommended, and less than half deliver in health facilities. So what all of this does is that it can lead to infection and disease. So, and that in turn will lead to malnutrition. So it's like a vicious cycle. So poverty and lack of resources are the basic causes, and that leads to these 4 in terms of food access, childcare, water and sanitation, and health services. That will lead to insufficient dietary intake and infection and disease, which may impact on malnutrition, which will lead to either mortality, or if the child is growing poorly, they'll have repeated diseases or morbidity, and that can affect their productivity. So on top of that, recently the flood situation has also impacted very severely on the on children's nutrition in affected areas. So according to the UNICEF press release, more than 1 in 9 children under 5 that were admitted to health facilities in flood-affected areas of Sindh and Balochistan had severe acute malnutrition. And so obviously one problem has been that all the crops have been affected, right? But on top of that, children's nutrition has been affected because not only could they not get access to food, but they had, like 1.6 million children only in Sindh and Balochistan province alone, and we have not looked at other provinces, could be suffering from severe acute malnutrition and they need urgent treatment. The problem is that malnourished pregnant women are also at risk of giving birth to low birth weight babies who might also be malnourished. And apart from lack of access to to crop food because of what has happened to the farming and the crop yield, poor access to safe drinking water and hygiene because of the floods will also increase the risk of malnutrition and wasting. It can cause diarrhea and prevent children from getting the nutrients that they need. And it also increases the probability of open defecation from 1/3 before the floods to over a third of the affected population. And then we see that there was an increase in water-based illnesses that were spreading. For example, gastroenteritis and diarrhea and skin-related diseases and typhoid and cholera. And then, of course, millions of people lost their homes, livestock, and livelihoods, and they will be vulnerable to malnutrition and health problems. So, what are some of the policy solutions to address this? So, when we think about nutrition of children, we also have to think about it in the context of climate change, because when we think about some of the problems we've had in many countries, either we see a sharp increase in flooding, sharp increase in droughts. Droughts are becoming more frequent, and flooding is also becoming more common and more severe. So these are affecting food systems, these are affecting diets, these are affecting nutrition, and the health is and disproportionately impacting on marginalized populations. So the Global Food Policy Report had a special report on climate change and its impacts on food systems. And some of their recommendations are that climate change is projected to reduce agriculture GDP through declining crop yields and increase in consumer prices. This is going to make it more difficult for poor households to afford to buy nutritious food everywhere, not just in South Asia, but also in Africa. And these will have direct impacts on and long-term impacts on food and nutrition security. We see that poor households will be highly vulnerable to extreme weather events due to chronic food insecurity, lack of access to formal safety nets, and we do see that poor households have a high reliance on climate-dependent agriculture. They may have limited resources and capacity for mitigating and adapting to the effects of climate change. So in the context of South Asia, some of the policies that have been recommended in this report are to rationalize the food, fuel, and fertilizer policies that are very generous at the moment. For example, the report argues that in South Asia, we produce a lot of rice and wheat, and these are taking up a lot of land, and the fuel and fertilizer policies are highly subsidized, and fertilizers are increasing, certain types of fertilizers are increasing the nitrogen dioxide emissions. And what are the ways in which we can adapt to climate change, and so that we don't focus simply on food production, but also understand that we need strategies to be able to have adapt to shocks. So they also, when we look at solutions to maternal nutrition, we see that there is a lot of guidance on maternal nutrition, and the focus has been on improving the diets of mothers during pregnancy, and they offer solutions like fortification of of food and biofortification, and having a supplementation program, food supplementation with iron and vitamins. But the focus has also been on service provision during the preconception and pregnancy stages. But there are still gaps on global guidance on diets and practices for mothers after the children are born. And if we look at current policy initiatives in Pakistan, there are many good policies. For example, they have the Lady Health Worker Program, which is implemented nationwide. These are offering health and nutrition services to improve access to these services in rural areas and urban slums. And the lady health workers are making home visits to advise pregnant women on maternal nutrition, family planning, counseling on health, nutrition, hygiene, antenatal and postnatal care, and how to prevent anemia. So, but of course, for a large country, it's not possible for just 90,000 workers to be able to access all the areas. And in addition, there are also community midwives who are, addressing some of these needs. And each provincial government had different provincial governments had different programs to address maternal and nutrition related intervention. So very recently, what the Pakistan government has put together a Pakistan nutrition strategy, and it's a comprehensive document where what they're trying to do is have a strategy for the next 5 years, and as part of that, they want to make it a comprehensive strategy that is able to deliver on the maternal nutrition and child nutrition needs. So some of the policy solutions have been taken, for example, from the World Health Organization's antenatal care recommendations for nutrition for women during pregnancy. For example, counseling on healthy eating and being physically active, nutrition education on improving the daily energy and protein intake in undernourished populations, and balanced energy and protein dietary supplementation among undernourished population, and lowering caffeine intake during pregnancy. They're also doing interventions through micronutrient supplementation, such as daily oral iron and folic acid supplementation, iron and folic acid supplementation at periodic periods, calcium supplementation, vitamin A, zinc, and multi-nutrient supplementation. So this is the comprehensive maternal nutrition strategy that the government has adopted, and this is a very comprehensive 250-page document. And what they want to do with this document is understand that it has been formulated after extensive discussions with different ministries and different provincial governments and key stakeholders, and the aim is to protect and promote healthy diets, practices, and services that support the optimal nutrition, health, and well-being of women. And they have done it in the context of the 2 SDG targets around nutrition, which is 2.1 and 2.2, is to end hunger and to end malnutrition. So they have 3 main strategic areas of progress. Under each of these strategic areas, they've got sub-strategies, and they have a detailed implementation program to address this. For example, the first strategic area is to create and sustain an enabling environment for maternal nutrition. So what they want to do here is to strengthen the policy and coordination for the evidence-based and equity-based inclusion of maternal nutrition interventions. They want to strengthen the financing and resource allocations for maternal nutrition. And they want to strengthen advocacy and awareness of maternal nutrition by designing social and behavioral strategies that target different audiences. We also see next that the second area of strategic focus is on is to design programs and implement maternal nutrition interventions with equity and at scale. And they want to do this at the health sector level, at the other sector level. And the third one is to strengthen the preparedness and responses in disaster-prone districts, and for these districts potentially also to be able to implement in emergency situation. And the final strategic area is to guide evidence-based programming for maternal nutrition through monitoring, evaluation, accountability, and learning. So what they've done is they've taken the child nutrition indicators from the Pakistan Nutrition Survey that I just showed, National Nutrition Survey, and they have got aspirational targets for what they think it should look like after they do these interventions over the next few years. So it's a very detailed document. It's quite a good document working in conjunction with provincial governments and also different ministries. So I guess I will now come to my conclusion, but then open up for questions because we can have more discussion. We see that malnutrition among mothers and children have long-run consequences. South Asian countries have among the highest proportions of food insecure people, and we also have the highest proportions or numbers of malnourished children and mothers. To give you an example, countries in sub-Saharan Africa have much lower GDP per capita compared to countries like India and Pakistan, but we see that the stunting incidence in sub-Saharan African countries is not as high as it is among South Asian children. And different countries have implemented several strategies to address this. And what we see that at the household level, better access to education, income, and access to information on nutritious food and access to health infrastructure can, of course, help in addressing maternal and nutrition, child nutrition. But we see that the adoption of this new Pakistan nutrition strategy is a good step that has been taken to consolidate what is going on between different provincial governments implementing different programs. And sometimes we see that there's no monitoring of different programs, there's no evaluation. So what this nutrition strategy is seeking to do, is my understanding, is that they want to have some targets for what they want to achieve, and they want to implement a whole of country approach, and they want to do it in coordination with local stakeholders to ensure that the nutrition indicators in the next 5 years will improve through a coordinated strategy. So I think this is the end of my presentation, but I'm happy to address or elaborate on any aspect of my talk. Thanks.
Thank you very much, ma'am, for a very comprehensive presentation. And the house is now open for question and answer session. And before that, I would like to invite Dr. Vinesh Sarwar Khan from National Institute of Food Science and Technology and co-chair of Policy Advocacy and Research in Pakistan-Korea Nutrition Center. Madam, would you like to add something, please? Dr. Benish, are you there? I'm not sure whether she can listen.
हेलो जी सर सॉरी
Yes,
वो मेरा
yes.
माइक में से ओपन करने की कोशिश करी थी बट जी
It's all right. So please, if you want to add something, you want to add something about the Pak-Korea Nutrition Center's activities, sort of things.
Okay, sir. Thank you, sir. Thank you, Dr. Anu Rammohan. That was a wonderful presentation and really adds to our further. Previously we all are working on this field, and it really adds up to our knowledge. I really want to update all the audience about our Pak-Korea Nutrition Center. Pak-Korea Nutrition Center is going to be happen in collaboration with KOICA and University of Agriculture, Faisalabad, and HEC, Higher Education Commission, Pakistan. In this project, there are 7 thematic chairs like public health and nutrition, compositional analysis, product development, food processing, and policy advocacy and outreach. And the major theme and the major work of that Pak-Korea Nutrition Center is better nutrition for children and community. And the major focus is already on females, pregnant and lactating mothers, and children under 5. And in this project, we will work through 5 stakeholders. The very first stakeholder is lady health supervisors, lady health workers, school nutrition supervisors, primary school teachers, and nutritionists and dietitians. And all these stakeholders will be trained, and these stakeholders will further cascade this knowledge to their public and community. So this presentation and this lecture is also in connection with that Pak-Korea Nutrition Center, and Dr. Khalid Bashir is working in Pak-Korea Nutrition Center policy advocacy and outreach chair. So we are really looking forward, ma'am, to collaborate with you in Pak-Korea Nutrition Center and policy advocacy outreach chair to add up in our knowledge and to add up some very good suggestions from you and people like you to bring good results from that Pak-Korea Nutrition Center. Thank you, sir. I hope that I explained PKNC.
Yes, thank you. Yes. Thank you, madam, for explaining about the role of PKNC towards achieving the national nutrition strategy of the country. All these 7 thematic chairs are basically in line with the national nutrition strategy, and we are all working towards achievement of the goal. And we have regional partners from every province of the country, and we will definitely, it will be a good change towards achievement of
Sure.
goals. Dr. Amjad, you have a question.
Thank you, sir. Can you hear me?
Yes, we can hear you.
First of all, I am very thankful to Professor for sharing a very informative presentation about maternal and child nutrition. In South Asia, from your presentation, I got specifically in Pakistan, all the nutritional indicator in women starting from the pregnancy and in neonatal and infant and child are on the lower side. It's amazing and wonderful, madam. You have gone through all the aspects from my country as a case study. So I have two basically part of my question. The first part is after studying Pakistan as a case study, starting from history, I think 40-50 years, you studied our last 40-50 years. So what do you think, what are the concluding gaps categorically you find out from all of your keen research in our country. And the second part of my question is how our girl or woman can learn from your country experience to raise all these indicators. Thank you, madam.
Thank you very much for the question. And no, it's very interesting. And I really would like to collaborate with you. I've done a lot of work on India and Indonesia and Myanmar on nutrition. And it's very interesting. And I see, for example, what is going on in Indonesia. And they have really good local implementation, which we don't have in India and Pakistan. Yeah.
Yes, madam, I can hear.
Yeah, sorry. So what we have, a problem we have is, I think, a problem of implementation. We have good programs, but they're not implemented properly at the local level, maybe. And I think one of the big problems is poverty for us, right? In poor areas, when there's a lot of poverty, we see that, we see, for example, Sri Lanka had poverty, but they were able to implement it more easily than India or Pakistan. And India is much worse than Pakistan, I can tell you, on all the indicators here. We don't know what, I think part of the problem is the, poor access to health infrastructure, maybe early child marriage, but I think at least having now this new comprehensive nutrition strategy should be able to, improve the implementation of these programs, right? So what is not working well, I think maybe for bigger countries, more spread out, the implementation is a bit of a problem. And maybe at the local level, the monitoring and evaluation is not happening. And maybe the government is just putting money there, but not actually seeing whether one program may not fit in every region, right? What might work in, Punjab may not work in Balochistan or Sindh, right? So I think we need to be able to understand that what works in mountain areas may not work in plains, right? And maybe in Punjab, they have access to food because good, production. But maybe, in the border provinces, mountainous, they can't access, difficult for them to access the health centers, right? Maybe they need a slightly different approach there with more lady health workers being able to go to their houses there. Maybe some solutions like that. But I think those are some of the problems. And of course, poverty is a big problem.
Yes, obviously, poverty is the big problem. Even before poverty, the knowledge and education, that is a bigger issue. Like you have just mentioned about Sri Lankan handling about the issue, that is perhaps due to much better knowledge and education situation in the country. People were much aware of malnutrition and all its allied issues. That is why the policies were implemented in a better way. The second thing that you have, I will endorse you about a policy, a national policy might not, a blanket national policy might not work. That was also a key finding of my PhD dissertation, that there should be this disaggregated approach. And that is why the Pak-Korea Nutrition Center has formed 7 thematic chairs, and we have provincial partners, and we have partners from Kashmir as well, and we have medical colleges with us. That will be spreading the knowledge. The policy advocacy chair will spread the knowledge across all the boards, and rest of the chairs will blend different types of food, that is fortification of foods, and that will be delivered to the specific areas. These 2 points, I think, are very much important the disaggregation as well as the knowledge. If you have enough knowledge, you can people have enough knowledge, they can adopt your strategies quite easily, and the progress will be faster as compared to the region. Any other questions, please?
Yes, sir. Thank you. I think one more point that should be addressed in our society, that is about diversification of food. Our local society have the same pattern of food from the last 40, 50 years, and our women or girl do not have the knowledge about diversification. So to improve the nutritional status of our women, we should focus to give them aware about diversification. Thank you, sir.
Of course, you are right that diversification is important, but I think over the last 40, 50 years, we have gone down towards diversification. Like when I was a child, always when I visited my village, I used to have duck meat and variety of foods. But now, if you look in what is happening in our villages, they are also after pizzas and shawarmas, etc., etc. So we have already destroyed the diversity over the last 40, 50 years. We were better off as compared to today when we were a child.
Yes.
I hope.
Yes, sir. I mean, Doctor, I really want to endorse to Dr. Khalid, and I want to update everyone that right now, according to survey, there is only 3.6% minimum diversity in Pakistan. Just only in total population, only 3.6% people are having at least 4 food groups every day. Otherwise, all other 96% people are not even having 4 food groups per day.
Yes, very true, madam. Because I think what's happening is before the traditional diet was more nutritious, like what we're doing now, we are going to a Western diet. So if you go to villages, they are eating chips, and they're not eating, and they're eating more rice. They are cutting back on millet and sorghum, right? Millet, bajra, and cutting back on that, and cutting back on milk and things like that. Traditional food is going down, and we're eating pizza. We're not eating fruit or vegetables, which we used to grow in the garden in the village, right? We are eating, what's available. Yeah. So I think that's true.
And there was another question in the chat from Said. He was talking about the political motivation and political factors that influence policy implementation and sort of things. To me, yes, that is a very important factor. In countries like Pakistan, India, Bangladesh, most of the policy decisions are motivated due to a lot of political, maneuvering. So this is an issue. So what would you say, Professor, about it?
I think you're absolutely right. I think the other issue is conflict, right? If there's conflict in a region, that affects the access to services, for health services. For example, the children will not be able to get vaccinated on time. The mothers will not be able to access the health center to get, antenatal care. So areas where there has been conflict or political trouble, or we have in India and Pakistan, we have riots, we have strikes. These actually affect delivery of services to those regions. So I think that has a bad effect on maternal and child thing.
Yes, obviously, and also a lot of political turmoils when different things happen in the country. There are strikes, there are public processions, political processions. These sort of things also affect not only the economy, but also the micro level nutritional subjects as well.
Yes.
Do we have any other question, please?
There's one in the chat from Nimra. Why people are not using nutrition food? Yes, I think partly poverty, they can't afford it because nutritious food is expensive, but partly because don't want to eat traditional food. They are cutting back on traditional food and they are, copying what is happening in Western countries. And plus, we have to think about conflict, like in Ukraine, it's affecting the fertilizers, it's affecting access to grains, food grains, and that is also increasing prices and inflation, right?
Yes, definitely. Do we have any other questions? If we don't have any question, then I would like to wrap it up with a special and big thank you to Professor Dr. Rammohan for sparing some time for us. And I hope that Dr. Binish will be in touch with you soon about any collaborative work or study under Pak-Korea Nutrition Center.
Yeah.
And also, I would like to request you for a copy of your presentation, if you can give it.
Yeah, I can send it to you.
So that we can have a two-pager policy outcome of today's discussion.
Sure.
Obviously, I have the recording as well. We can do it.
Yeah. No, I'll send you the presentation. Yeah.
Yeah. Thank you very much, Madam, once again, on behalf of University of Agriculture, Institute of Agricultural and Resource Economics, Pak-Korea Nutrition Center, and Office of Research and Innovations of the UAF. Thank you very much for sparing some time for us. Hope to see you soon.
Yeah.
Thank you once again.
Thank you very much. It's been a pleasure. Thank you for inviting me. Thank you. Bye.
Bye-bye.